Hello, my name is Jason Gillon, and this will be a review of renal and bladder point-of-care ultrasound. Flank pain and/or hematuria are the primary indications to perform renal ultrasound. This allows for assessment of hydronephrosis, which has several etiologies in the pediatric population. Calculi or stones are one of the primary causes of hydronephrosis, and these can often, but not always, be directly visualized with ultrasound along the urinary tract. Renal masses are also readily detected with ultrasound. Point-of-care bladder ultrasound allows for qualitative or quantitative assessment of bladder volume. This can be useful to assess for urinary retention in patients, to make sure the bladder is adequately filled prior to a transabdominal pelvic ultrasound in females, or to make sure there is enough urine present prior to catheterizing a patient to obtain a urine sample. It is important to note that renal ultrasound is not generally useful in the evaluation of pyelonephritis and will be normal the majority of the time, so pyelonephritis principally remains a clinical diagnosis. So which transducer should we use for renal and bladder ultrasound? The curvilinear probe is most frequently used. It allows for the depth generally needed to image organs while producing a relatively sharp image. The phased array transducer does not produce as sharp of an image, but its smaller footprint can make it easier to maneuver between ribs if that is an issue. Lastly, the linear probe can be used in infants to produce very sharp images, since you don't need a lot of depth to image these organs in infants. To image the right kidney in its long axis, the transducer is placed in the patient's mid-axillary line as pictured, with the indicator pointing toward the patient's head by convention. The kidney is fanned through by tilting the transducer toward the ceiling and toward the floor, taking care to not slide the transducer until the entire organ is visualized. To image the right kidney in its short axis, the transducer is rotated counterclockwise with the indicator pointed toward the floor to maintain the general scanning convention of the indicator facing toward the patient's right if not pointed toward the head. If rib shadows are a problem, the transducer can be slightly rotated along the axis of the ribs to minimize this. Again, the kidney is fanned through from the superior pole to the inferior pole by tilting the probe toward the patient's head and then toward the patient's feet. Imaging the left kidney in long axis works the same way as the right kidney, with the indicator oriented toward the patient's head, except you will generally be along the posterior axillary line rather than the mid-axillary line. Also remember that anatomically the left kidney is slightly more superior than the right kidney. Conventionally, you will be scanning from the patient's right side and therefore reaching across the table to scan the patient's left kidney. To image the left kidney in short axis, you will again turn the transducer 90 degrees counterclockwise, which on this side will lead to the indicator facing the ceiling instead of the floor, but this still follows the convention of pointing toward the patient's right side, and again you will fan through the entirety of the organ. To image the bladder in transverse view, the transducer is placed just above the patient's pubic bone with the indicator pointing toward the patient's right. The bladder is fanned through by tilting the transducer toward the patient's feet and patient's head to image the entire organ, again making sure you are not accidentally sliding the transducer. For small underfilled bladders, you often need to angle the transducer into the pelvis as you may not be able to visualize the bladder if your transducer is perfectly perpendicular to the patient. To image the bladder in sagittal view, the transducer is rotated 90 degrees clockwise, so the indicator is pointing toward the patient's head. The bladder is fanned through by tilting the transducer toward the patient's left and right until the entire organ is visualized. Again, you may need to angle the transducer into the pelvis to center the bladder on the screen. In this slide, we will discuss calculating bladder volume. Most modern ultrasound machines have the ability to split the screen to visualize two separate images next to each other, and also may come with calculation packages that can automatically calculate bladder volume. If your machine does not have these options, you will need to manually record the dimensions and calculate the volume. In dual or split screen, you will obtain the largest image of the bladder in both transverse and sagittal views. In transverse view, you will measure two dimensions by making a plus sign. In the sagittal view, you will measure the third dimension by making a minus sign, but this may not be perfectly horizontal as you want to measure the longest axis, which in fuller bladders tends to slope downwards. It technically does not matter which side you make the plus sign and which side you make the minus sign. As you can see in the formula that all of the dimensions get multiplied together, so it is not important to know which dimension is which. This common formula assumes an ellipsoid volume of the bladder, which uses pi over 6 or 0.52 as a coefficient, but there are other formulas that have been described. Note that if you made a vertical line instead of a minus sign in the sagittal image, you would be measuring the depth twice and not measuring the height. In a normal kidney, the renal sinus, which contains the renal pelvis, fat, and blood vessels, is relatively hyperechoic. The surrounding renal parenchyma is relatively hypoechoic to the renal sinus, with the renal pyramids, which are marked here by the asterisks, relatively hypoechoic to the renal cortex and columns. The echogenic differentiation between the pyramids and cortex is more pronounced in younger children, like the 6-year-old in this image, and this differentiation becomes less apparent as the person ages. Before showing sonographic images of hydronephrosis, it is important to review the grades of hydronephrosis. There are actually several different classification systems, but I prefer this one due to its simplicity. In mild hydronephrosis, the dilation is restricted primarily to the renal pelvis. In moderate hydronephrosis, you have some degree of dilation of the renal calyces. Moderate hydronephrosis can range from dilation of some calyces with the integrity of the renal papillae, which are the tips of the renal pyramids, maintained, all the way to uniform dilation of all the calyces with blunting of the renal papillae. In severe hydronephrosis, there will be parenchymal compromise with thinning of the cortex. I've heard hydronephrosis described like a tree. If you just see the trunk, it's mild hydronephrosis. If you can make out any branches, then it is moderate hydronephrosis. Finally, if it has the contour of a tree with leaves, it is severe hydronephrosis. Here's an example of mild hydronephrosis, where you can see dilation of the renal pelvis. It is important to confirm this with color Doppler, as the renal vasculature can sometimes be mistaken for hydronephrosis. As you can see in the image on the right, there is no flow signal detected over the anechoic area of the pelvis, confirming it is hydronephrosis. Here's an example where one can mistake this anechoic area of the renal pelvis for hydronephrosis. However, when a color Doppler box is placed over the area of interest, a flow signal is detected, confirming that this is in fact renal vasculature and not hydronephrosis. Here is an example of moderate hydronephrosis. You can see that the renal calyces are beginning to become dilated and visible, or in other words, you can make out the branches on the tree trunk. Lastly, here is an example of severe hydronephrosis. You can see that thinning of the cortex is quite pronounced. This is often referred to as a bear paw sign, given the resemblance. Not uncommonly, you will come across the renal cysts when performing renal ultrasound. These are usually well-circumscribed, purely anechoic lesions. Sometimes renal cysts, particularly multiple cysts, may be misinterpreted as hydronephrosis. However, if there is no dilation of the renal pelvis, there is no hydronephrosis. You can see the renal pelvis in this clip is normal, which I often like to describe as tight and bright. Occasionally, you might see a renal mass when evaluating a patient for flank pain or hematuria. The mass can be of varying echogenicity and may have cystic components, but you'll often see a derangement of the normal contour or shape of the kidney. This is an ultrasound of a 15-year-old who presented with vague left flank pain and gross hematuria. You can appreciate a complex cystic lesion at the inferior pole of the left kidney. This particular mass ended up being a Wilms tumor on pathology, although renal cell carcinoma was highest on the differential pre-biopsy given the patient's age. You will sometimes be able to visualize calculi or stones along the urinary tract, including non-obstructive stones within the collecting system, obstructive stones around the ureteropelvic junction, which is the junction of the renal pelvis with a proximal ureter, or at the ureterovesical junction, which is the junction of the bladder with a distal ureter, both common locations for stones to get stuck. Stones generally appear as a bright echogenic focus, and you can often visualize some clean acoustic shadowing. So here's an example of an obstructive stone at the ureterovesical junction, which shows why it is important to image the bladder in addition to the kidneys if you detect hydronephrosis. You can see that the ureter imaged in short axis here is dilated and visible as well. Stones often demonstrate what is called twinkle artifact. If you place a colored Doppler box over the suspected stone, you can see a flow signal even though the stone is clearly not in motion. The exact mechanism of this artifact isn't completely understood. Here's another example of twinkle artifact of a stone at the ureterovesical junction. You can see it appears like turbulent blood flow once you put the colored Doppler box on it. So here are some pearls and pitfalls of renal ultrasound. Renal ultrasound includes imaging of the bladder. since the urinary tract is all connected, so remember to obtain these views and not just focus on the kidneys. Make sure to maneuver around rib shadows as best as able, especially for any shadows projecting over the renal pelvis. This can usually be done with slight rotation of the curvilinear transducer between the rib spaces. You can also try the phased array transducer with its smaller footprint to troubleshoot this. Remember that for mild hydronephrosis, you want to confirm that it is in fact hydronephrosis and not renal vasculature by interrogating the area with color Doppler. Renal cysts are discrete lesions and can be distinguished from hydronephrosis by making sure the collecting system is not dilated. For bladder volume assessments, remember it's plus minus and not a vertical line, or you will double measure the same dimension. Point-of-care renal ultrasound for hydronephrosis, as suggestive of a renal stone, has only demonstrated modest diagnostic accuracy in adult studies. So remember, this study should not necessarily be used in isolation, and you need to consider other clinical data, other imaging, or urology consultation when necessary. More dedicated pediatric studies are needed to help clarify the role of point-of-care renal ultrasound in this population. So let's review this case of a 7-week-old male presenting with intermittent non-bloody non-bilious emesis for a couple of days and decreased urine output. He was seen earlier that day by his primary medical doctor and diagnosed with suspected GERD, but presented to the ED later that day for no wet diaper in over 12 hours. So his physical exam was essentially normal, as were his vital signs. He had no clinical signs of dehydration, but there was a drop of urine noted at his urethral meatus, although his diaper was dry. The differential diagnosis for this patient included gastroenteritis with dehydration, pyloric stenosis, or some sort of obstructive uropathy. Point-of-care ultrasound was particularly useful for evaluation of this differential. Bladder volume could be looked at to determine if the decreased urine output was dehydration-related or obstruction-related, and pyloric stenosis is evaluated with ultrasound. First, the patient's bladder was evaluated, and here's a clip of the patient's bladder in transverse view. What you can see in this clip is a distended bladder with a thick bladder wall, shown here with the white arrow. The anechoic structure is visualized deep to the bladder, marked by the asterisks in the still image, represents significant dilation of the ureters. Here is a clip of the patient's right kidney and lung axis. This patient has severe hydronephrosis disrupting the cortex. The areas of hydronephrosis are marked in the still image by plus signs. The asterisk represents some perinephric fluid that in this setting would be consistent with calyceal rupture. And here's a clip of the patient's left kidney. Again, you can appreciate severe hydronephrosis with disruption of the cortex. The areas of hydronephrosis are again marked by the plus signs and the perinephric fluid by the asterisk. The arrow is pointing to a very thin rim of renal cortex between an area of hydronephrosis and the perinephric fluid, which again suggests rupture of the renal calyx from such high pressures. Overall, these findings are consistent with some type of bladder outlet obstruction, which in an infant male is most likely going to be posterior urethral valves. This patient ended up going to the ICU due to severe hyponatremia. His bladder was decompressed with a urinary catheter, and avoiding cystourethrogram confirmed the diagnosis of posterior urethral valves. Once stabilized, he was discharged home and later had ablation of his posterior urethral valves. In summary, renal POCUS is a great first evaluation for flank pain and/or hematuria. The test characteristics, operator dependence, and inter-rater reliability need to be better studied in the pediatric population. Remember that when we say renal ultrasound, we really mean renal and bladder ultrasound, so don't forget to image the bladder as well for a complete study. Lastly, assessment of bladder volume is a quick and relatively simple evaluation and is useful in certain patients, such as when there is concern for urinary retention or to make sure there is urine in the bladder before catheterizing a patient so you can avoid a dry cath and repeat attempts.